first and foremost, we are going to do the block. So what is this block? It is that molar here. This is the molar that you are going to do, right? I pick up this molar because I found that it has a curvature from mesial to distal and from buccal to lingual in one on the MB canal, in the mesiobuccal canal. The mesiolingual canal is just one curve, and the distal is very flat. So this is the kind of situation that you are going to use. When I did the CAD/CAM, I turned a little bit more curve here. I increased a little bit the curvature just to make sure that you guys are going to do something a little bit different. As you can see, this guy here is spinning. This is the micro CT image of that molar that we CAD/CAM the micro CT image and we turn into this block and we print it in a 3D printer, like you were saying. So sometimes you say, I'm going to do hands-on, right? And you have those little blocks, and you do the blocks, and you say, well, but how about the real situation? Well, this is the closest that you can get. Actually, the resin here is a special resin. It is not super transparent, unfortunately, because it has this almost the same resistance than dentin, right? So you are going to feel almost exactly the same thing. And I'm saying almost because dentin varies a lot in terms of density. If it is an old teeth or old tooth, then you have more compact, less organic, so it's harder. If you have a very young, it will be softer than this one. So it's very hard to pick up exactly the same situation, but will be average, okay? So you see it's 12 hours to print 50 blocks. And actually you are going to see Ultradent logo because it was made by Ultradent. They are not doing it anymore. So once finish these blocks, I cannot do my hands-on anymore. So I'm trying to find somebody who will do these blocks for me, but it's being very, very difficult. It's kind of $5 each, and it's the amount of the number is not matched. They want to do 10,000. I cannot do 10,000, $5 each, you know. So this is the buccal face of the block. So if you see in front of you, you see Ultradent there, the logo. In your right, that will be mesial. In your left, that will be distal. And of course, you see the pulp chamber there. I elongate a little bit this pulp chamber just for our use, right? And you see down there, there's this little space here. And this little space here actually is, if you see down there, you can see the 3 little foramens there. You have to see with loops or even microscope. But you can see the little 3 foramens. The diameter of these foramens is 0.15. So this is not the average 0.27. For purpose, I constrict a little bit to be more calcified situation, right? So in terms of difficulty, this has the mesial buccal that is double curve, difficult. Then you have the mesiolingual, this one curve, let's say average standard. And the distal, it is difficult as well because it's flat. It's not because it's curved, but it's because it's flat. So you have to clean everything, right? And you are going to see during instrumentation that you cannot clean, during irrigation that you can clean. Canals are filled with some sort of support material. The texture is like wax, let's say, is more or less like that necrotic tissue without a lot of humidity, but staying there. So it's pretty hard to remove, okay? But you guys will. So if you see the upper part of the block, so you see this little ditch here. There's a little ditch here, right? This is the back part of the block, or the lingual part. The front is the buccal part, right? And then you have left and right mesial and distal. So when you see the block for finding the canals on your axis, let's put it this way, you don't have to do the axis, but you have to find the canal entrances. This is the distal, mesiolingual, and mesiobuccal. Okay? Lengths. Of course, you are not going to determine the working length on this block. We are going to use another setup for playing with the apex locator, most probably after lunch. But this is the length that I know, we know, but let's pretend that you don't know, right? You are going to determine with your apex locator, but you cannot use the apex locator with this block. So you are going to pretend that you are determining, but it will be 18, the working length for the mesials will be 18.5. 18.5 is the cleaning working length. Cleaning. Right? So you are going to use 18 for shaping. 0.5 to 1 millimeter. In a clinical basis, 1 millimeter. Here I will use 0.5 because I know, because we manage everything, right? So your patency file will be 18.5. Your file, the Genius Proflex files, will be 18. Is that okay? Oh, sorry, 19.5, 18.5. So patency files will be 19.5, 18.5 will be your Genius files. Shaping. And we are going to do this back again. Remember that I told you guys about a site that you can download this hands-on. So you go to medidenta.com and you press Endo here. You open this little menu. You go to ACE Sonus Genius Interactive Hands-On. Go Endo and then ACE Sonus Genius Interactive Hands-On. You click there and it will automatically download a PowerPoint file. This PowerPoint file you just download, put in the folder that you want, and then when you double click, it will open a presentation that you can interact. Let's do this now, and I show you super easy. So I will go to medidenta.com. Here you go, Medidenta. I'm going Endo here and ACE Sonus Interactive Hands-On, right? When I do that, automatically I start to download this, demo here, right? So I will cancel because I already have, of course, I did it. So I will show you this. Demo trade show, and here you go. So I double click on the demo trade show or demo, whatever is the name of the file. I think that is hands-on demo, and will appear something like this here. So you don't have to do anything, just wait. Here you have table setup, your table setup, block details, the block details, sonus setup, sonus tips, ACE setup, irrigation, apex locator, Genius AutoSense. Let's say that I want to see the sonus tips, right? I just go here. You have the trumpet, you have the scout, you have all the sonus tips that comes with your sonus. And you have those videos that I showed you, right? Let's say that I want to go home. Let's go home, finish the video, and I want to see, for example, my sequence. So number one is scout. So there's a little video showing how to do Scout, and so on. So it's very interesting, very interactive. All the information that you need is here. Every time that you press the little house, the little home goes to this main. So in here, let's say that I want to see the initial irrigation with my polysonic tip and my sonus. I just press there, number 2 here, right? Let's say that I want to know how to use the curvature sweetener. I just press here in the curvature sweetener, and it goes automatically to the video showing initial, sunscreen, and the curvature sweetener. And it's me, as you can see. See that? Yeah. Everything I did by myself, these videos, without any help. Yeah, you're laughing. I know. Oh, you were not there. Yeah, you were not there. And my voice in the video are so bad that I put subtitles because it's horrible. My voice is horrible, and my English is broken, so it's a perfect nightmare. Okay? So that being said, I recommend you, because you are going to train a little bit more, I recommend you to take a look on these videos, reproducing extracted tooth, right? Then to have a better approach, you have these files, you can use these files, you are going to have more. So train a little bit before, just to make sure that everything is under control, and then go to your patients, right? Okay, awesome. So now let's play a little bit with really? My belly is too big, so when I see the thing just, so I put here. Thanks, David, for your help. You're welcome, cynic. Okay. So, as you can see, here's the block. So you guys just please take a look. You don't need to do anything now, right? So again, mesial, distal, so mesial buccal, mesial lingual, and distal. When I made this block, I made a little bit separate the mesial lingual for the mesial buccal just for view purpose, right? For demonstration purpose. So I will take a number 10 or even a number 15 file just to scout the canals, okay? So that is when I will use my little syringe with some water that I don't have. But I will have. Oh my gosh. Oh my gosh. I have to put this. I just pick up some water. Excuse me. David. David? Yeah, you have to. Oh, he's not here. You have to. So it's always good to have some, we have to take some pictures as well. So it's always good to have a syringe with sodium hypochloride, right? So I pick up my syringe, fill with sodium hypochloride. That is water here, but it's sodium. And then I will fill my canal with sodium hypochloride. Fill the pulp chamber, right? Just like that, okay? So I will take number 15. I take the number 15 and I will just scout, right? So I'm scouting here, scouting there. Distal, mesiolingual, mesiobuccal, yes, they are there. They are good, okay? This is scouting. I put my file here in the little sponge. Here. In my little sponge. Okay? So first of all, what we are going to do you remember? We are going to flush this with my polysonic tip and sodium hypochlorite, and whatever is the depth but my polysonic goes, I will use my polysonic. Okay, so you take my handpiece, turn on the device that is in the back part, E, E, double E, that start to blink, reservoir, and I will put number 3. Okay, this is the setup for the polysonic. Okay, so double E because I want the timer 30 seconds, just to make sure that I'm using correctly. I'm taking this tip. This is the ED70. And I will put in my handpiece, just like this. So I start with my hands, of course, and fingers. Then I will take the flat wrench and I will just make sure that it's tight. It's less than 132. No, it's just a little, just a little tight like this. Okay, so now I have the connector. In this connector, just you to know, you see that I designed a little opening here. It's kind of a line. This is the opening for your irrigation goes and correctly follows the tip, right? So it's not one orifice, it's like a space that, believe me, we try so many different things, but under vibration you have to test to make sure that the liquid goes exactly where you want to.
Is this also the tip you burn the
Nope, no. The other tip that is in your little holder, that is for cut gutta percha. Yeah. So you take one polysonic tip. There's 2 lengths. There's a short and a long, and a long one. For this purpose here, you can use short or long, doesn't matter too much. Then you take this and you just put it like this. Here we go. Okay? You see? Do not turn on without water. It will melt. So the vibration will give you a super high temperature and the tip start to melt. Right? So always turn on this with irrigation or inside the canal. Okay? So if you want just to make sure if the irrigation is coming, remove the tip like this. Take a little reservoir like this one and press the paddle. Right? It's coming. Okay? So now that it's coming and I know that it's coming, I can do this. I can put the tip back. And now I can just do it like this. Beautiful, huh? Look at that. So it's too much water maybe. I can reduce a little bit. Especially here that we don't have vacuum. That is a little bit tricky. So what I like to do when I'm using, you guys will have gauze. It is right here. So you just take some of them, take a piece of gauze, and just do like this. So you are not making a mess. And of course I take the trays that was missing. So if you want, just pick up one of the trays when you're using not to make this mess, right? Assistance. When the doctor is using this, you are going to close the tip for vacuum, right? So in this sense, you can remove all the excess of the irrigation. You see I'm doing the distal now? Look at that. Maybe a little bit more. Maybe brighter, right? You can see? Okay, so look what I'm doing. I'm cleaning, cleaning, cleaning. Look at that. So nice. Look where is my tip. 2/3 of this canal is already clean without touching a file there. Use this extra cup here to put down in your block, right? I'm not doing this because I am the boss. No, there's no space there. Okay? So this is what I want you guys to do. You see? Beautiful. I'm cleaning. Look how clean is my canal now without even starting my instrumentation. Look at that. The yellow part is the, what I call is the wax or the support material, right? You see how clean it is after not 10 seconds that I use. I will do in the other ones. I will do in the mesiolingual as well. If I feel that the tip is under pressure, I just free the tip and it's just back and forth, back and forth, back and forth, back and forth. Okay? And I will do in the mesial buccal as well. Look at that. It's not cool? So instead of starting my instrumentation with all the pulp tissue and necrotic tissue or whatsoever that is inside the canal, I'm cleaning before with what? Sodium hypochloride. Oh, you have a friend in Brazil that is using distilled water, and I respect him. So yeah, you can, but try sodium hypochloride. It's better. I have another friend that is using 1% during instrumentation and 2% in the final. Then you start to complicate things, right? So you don't need that. As you can see, oh, this is good. This is beautiful. As you can see here, I have some material that went just out of the canal. You see that? Yes, I see, Carlos. Yeah. Okay, so yeah, that comes just with my irrigation. Super cool. At least I think that is. I'm having a hard time with it. Look at that. So all this part here. I put some poison in your coffee. David, it's for David. No, it's not you, it's David there. Dave, that guy, that beautiful young guy there. So all this part here were clean just with this approach. 10 seconds approach here, here, and here. Of course, I was not here. I was not here because my tip is not going. So what is the purpose of my instrumentation? Open space for doing this until here, period. That is the big purpose of yesterday all day. It's just to convince you guys that your instrumentation needs to be done. Why? Because I want to put my polysonic tips until here and clean everything. It's just a matter of open space for my irrigation. Instrumentation, open space for my irrigation. And of course, design a good space for my obturation as well. That is sure. Is that okay? Awesome. Now you are getting a better perspective of the thing, I guess. I hope. So now it's time to use my 2506. So this is the 2506. And I'm going to see my X-ray. For the distal canal, it doesn't matter too much because there's no curvature. But for the mesial and mesiolingual and mesiobuccal, I want to be something like here, right? So I'm going into the T of ultraden. Okay? Yes, I'm doing this if I have a motor. Ah, I do. And I will put in Genius AutoSense. So sometimes I will do a little bit more pressure just to start the Genius AutoSense, just for you to see at the video the difference between rotation and reciprocation. Super cool. Okay? So if I'm going to the T, I'm putting my file here to the T, right? And of course I have to determine my temporary working length, like this. You're going to do this in your X-ray. You do a measurement on the X-ray until the middle of the curvature. It is, let's say, 17. You put your file in the endo ruler, 17. 17 will be your temporary working length for this purpose. Is that okay? Is that clear? Okay. Sometimes I do things here, it's super fast, so you let me know. I will put Genius AutoSense. Here you go. And that's it. Actually, that's the only thing that I need to do in my ACE. After I set up, it is the only thing. It's just turn on and turn off. Forever, actually. I don't need to do any setup here. So clinicians is CR, clinicians research, Gordon Christensen, right? So they send some equipment for them, and one of the things that come, 90% of the doctors will adopt, they love it, but there's one comment there, oh, it's too much buttons. I said, yes, I agree, there's a lot of buttons there, but you just use once. And after that, if you want to change, then you have to use again. But we don't change all the time, right? Okay, so what happens is, this is a heat-treated file, right? Look what I can do with this file. I can do this, right? So because this file is very, very flexible, there's two ways of turning the file straight again. You can use your fingers or heated water. If you put in heated water, the file just go back to austenitic phase. That is super cool as well. That is the part that you say, whoa, that is cool. Yeah, thank you. Thanks. This interaction is important. So I will turn on here. This is rotation. So I'm gently going on the distal canal. I'm going this way just to make sure that I'm touching all the tips. 5 seconds, I stop. Okay? So I'm going to medial buccal and I'm doing the same, 5 seconds, medial lingual 5 seconds, and then a full irrigation cycle on the 3. That makes sense? So I'm doing to medial lingual. Look at the medial lingual, I can go a little bit further with some freedom because I don't have any double curvature there. 5 seconds. In 5 seconds, look how much debris I'm removing. Guys, this is a big deal, right? If I start to pack that debris inside the isthmus, and I remove all the isthmus from this block because it's for educational purpose, right? But look at that. I have another block with isthmus that you saw yesterday with the isthmus and packing. This guy will be packed on the isthmus. You'll never retrieve this, even with ultrasonics. Yep.
So we got 3 canals. Are you irrigating each canal simultaneously, or are you doing it all at?
It's up to you. Okay. It's up to you. It's up to your control. Okay. I like to do 1, 1, 1, irrigation, because I'm lazy. But you can instrumentation, irrigation. It's totally up to you. Honestly, it's better if you do individually. So you go irrigate. Then you are going to irrigate more. Actually, I need to teach like that. But as a lazy guy, as a lazy dude, you're a lazy guy dude. Okay, so yeah, it is better, but I don't think that will make a lot of difference, right? So I put here, and this is the double curve. So you have a curvature that you are seeing from medial to distal. But if you flip and see sideways, you are going to see from buccal to lingual as well. Just take a look in your block. You see from medial to distal, flip, And then you are going to see from buccal to lingual is a double curvature.
Are you going down like letting the bird do it, or are you doing like a pecking, or what are you doing to go down the canal?
I just leave, I'm showing you right now. So I turn on and I'm going up and down freely until I feel some resistance. Then I withdraw the file and do brushing, 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 and stop because it's more than 5 seconds. But I will do this in your hands. You're going to do this. Brushing, brushing. It's not this. It's not with your, what's the name of this part?
Wrist.
It's not with your wrist. It's just with your fingers, right? Wrist, fingers, finger, finger, finger. Not wrist, not wrist. Finger, 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 finger. Okay? This is a lightweight 150 grams. This is it's compared with Root CX, the 3 out of ZX, it is 179. So it's 29 grams more than this one. That makes a lot of difference, believe me. If you do endo every day, full day, at the end of the day, you're... So now that I did all this, I take a piece of gauze again, just to clean the stuff. And let's go back and let's do again. Same thing, right?
But before that, you're using the 15
No, I'm not there yet. Now I'm going to determine my working length and then I will use my 15. Okay? Let me take, where's my oh, here you go. So my 15 file, my patency file will be after I determine the working length. Okay? So I'm not there yet. So I'm trying to remove 2/3 of the canal content. Here you go. Okay, so now I'm going to do a lot of irrigation again. Beautiful. And I will do 30 seconds, right? Look at that. Look how clean you can get. So in the distal canal, with one file, 2/3 of the canal is done. In the mesiolingual, quite the same thing, right? Look at that. And the mesiolingual, mesiobuccal, I'll do 30 seconds. Pretend that was 30 seconds, right? You are going to do 30 seconds.
What setting is that on right now? The E, you press E on the side.
E,
and then
power 3, double E, then the E is blinking, then you have the timer. Without just E, no timer, double E, timer, 30 seconds.
You want that at 2 or 3?
3. I am 3 right now. Yeah, 3. 3 is good. Okay, now is the time that I will, look, everything that is super white right now is already clean, right? So with the 2506, and I am being very frugal with my 2506. I can go a little bit further if I want, right? But let's keep on the safe mode, okay? So now is the time that I will determine my working length. So I will take a number 15. I take my number 15. I will turn on I will put the cables on my ACE. I will show this afternoon, right? But just imagine that I put in my number 15 here. I hook the lip clip, I hook the file clip, and I'm going to my working length. This is the cleaning working length. Frame and area. Beep. Okay. I'm coming here. I remove this guy, and the distal canal will be 18. So 17 will be my working length. Don't worry, we are going to revise all these measurements in a moment, right? So I'm coming here with my ruler, that is not here, of course. Thank you, man. So I'm taking, this is 19, so 18 will be my working length. 18 will be my shaping, 19 will be my hand file. For the distal. For the medials, same thing, I'm putting the file, medial lingual, I just remove, go to my ruler, that is 18.5, 19.5, 18.5 will be my shaping working length. And the same here in the medial buccal. Look, the medial buccal is a little bit more difficult to get in, so I'm doing these oscillatory movements like when you go to the clock and you do the, nobody do this anymore, but watch winding movements, right? Watch winding. So this is the way that I go to my frame and beep, I remove the file. Cleaning working length will be 19.5, shaping working length will be 18.5. Is that okay? Yep.
In the beginning, when you use the first file, is that when you're using the RC prep?
Yep.
Just the one time?
Just one time. Yeah, you're right. This is an option, but yeah. Just one time, because it's very hard to remove the screens, these products, from inside the canal when you use at the very end. At the very end, there's no need, actually. It's just for a better lubrication on this process that I just showed. Is that okay? So I determine my working length. Now it's time to transfer my working length to my Genius files. The first one will be the 2504. So we will transfer 18.5 to the medials, and I will do that right now. 18.5, that is 18, 18.5. I will remove my 2506 from my contra-angle, put back on the sponge, put my 2504, and now what I'm going to do is make sure that the canal is filled with sodium hypochlorite. If it is not, remember, you have this little syringe here. Just fill the canal. You don't need to do anything, but just fill the canal with sodium hypochlorite. And then 2504, the rubber stop is the color of the tip as well. So a green rubber stop is a 35. A red rubber stop is a 25. So I put the color of the rubber stop to match the color of the file. So here I am in Genius AutoSense, so I just turn on. We'll be in rotation. I'm going to do the medials. So look, I put my 25, and if I feel some resistance, I just withdraw a little bit, and 1, 2, 3, 4, 5 seconds, and I remove. Same thing on the medial buccal. I put the file. If I feel some resistance, I withdraw the file and brushing, brushing, brushing. 1, 2, 3, 4, 5, and I remove. Because the distal is a little bit different in terms of working length. Instead of 18.5 is 18, so I will put 18 here. Now it's 18.5. I'll put 18 here. Carlos, why you don't put exactly the same? Because I want you guys to remember that endo is about length and precise and accuracy, right? So you have to go back. This is 18, and now I'm going the same thing, and I'm going to do brushing movements as well. 1, 2, 3, 4, 5, and I stop. Circumferential, because the distal canal is a flat canal, so you have to do circumferential, right? Okay. Now is the time that I want to do another irrigation flush, a very good one. I will do that. Let's try to do this. Let's see if it works. So I will do another irrigation flush. You see that my tip now on the distal is almost getting there, because my tip is 0.28 and my preparation is 0.25. So it's almost there, right? If you want to transfer the working length for your tip, you just take your Sharpie here, to be dry. So you take the Sharpie and you transfer for your tip, right? So you put here, I need to do this with my own hands. Like this, I will put here, and I will just use my Sharpie to make a little mark. Is that okay? So I will do this, not in front of the camera. Here we go. Now I have my little mark. Now I know what is the length. Believe me, I try to figure out a better way of doing this, but it's complicated. In the near future, we are going to have one with marks, 18, 19, 20, and 24. But essentially, this is still the best way. So I'm doing now with the mesiolingual. There you go. 30 seconds. Right? That's why I have this little timer there that will give me one beep. Beep. This is a fake beep. Another one, mesiobuccal. Right? Little movements back and forth. We are so used with these little movements back and forth. There's no need of, but you can stay like this. But we do this just because we are so used of doing this, right? There's no need. But beep is over. So let's go now to the patency file, because I want my irrigation to flow passively in that area. So patency is this. Believe me, don't do differently. You put the file to the cleaning working length. Just like that, and remove. Super difficult, right? And again, the same thing for mesiolingual and remove. Same thing for mesiobuccal and remove. You're going to see people doing this. Again, because we are so used to do that, but there's no need. It's just to unplug.
Do you need to take x-rays with those?
If you are not very familiar with the apex locator, if you are not confident enough in your technique, yes.
You said working length, but did you really mean you want to take the patency file to the apical foramen, right? The
Yeah.
working length.
Cleaning working length. The cleaning working length. That is the original from 0, from your apex locator. That's why I'm using this dude. Why? Because this is the original one that I did my working length determination. That will be my patency file, right? Because this file already went there. Very simple. The setup is very simple. You see, one hand file, 2506, 2504, 3504. and a 40 for the distal. Just like that. Okay? So now that I have patency, look how clean is this canal now. It is already clean. Now it's just a matter of final shaping, right? So I will take my 2504 back because I want to make sure that it's going to the working length. And because I just stopped with 5 seconds, on the mesial buccal was not in the working length. So I will just go there, make sure that in my mesial buccal, that is double curve, I'm going passively there. You see that? Here you go. So I went there, 5 seconds I stop, just make sure that the mesial lingual is done, the distal is done, with the 2504 at least. And boom. What I do now I'm going to the 35, but before I'm going back with my cleaning. Carlos, this is boring. No, it's not boring. This is the fundamental of endodontics. It's to clean canals, it's not to shape. Shape is to clean, it's not the opposite. You don't clean to shape, you shape to clean, right? So again, I'm doing 30 seconds. Really? I will screw this machine. Here you go. So I'm doing again 30 seconds. Beep, 30 seconds. It's a fake beep. Again, 30 seconds here. 30 seconds here. Now my tip is going to the working length. Look at that. Super duper. Patency file. 1, 2, 3. Pull like that. And now my final file for the mesials will be the 3504. 3504 is a blue file. Oh, actually, is the blue heat treatment. Of course, it's a green file, but it's a blue heat treatment.
Do you irrigate right now and then do that? Do you irrigate first?
Yeah, I did the irrigation, patency, and now 35.
Okay, good.
Yeah, and it's 30 seconds each canal.
Carlos, are you checking with your apex locator with that?
Just if you have, okay, so you can, we are going to use the apex locator with the handpiece in cases of you want to make sure that you are not trespassing, right? Look, I want to simplify. I don't want to complicate anything for you guys. Of course, with time, you are going to see, well, maybe if I use the apex locator with my files will be better for me. So it's just hook a cable, right? And we are going to do this afternoon, but it's more a matter of your own judgment. It's good to have the tools and know how to use it, but not necessarily you have to use all the tools all the time. You know what I mean? So it's kind of under your judgment.
This is built in though.
It
On the ace, right?
on the base, yeah.
Yeah, okay.
And then you have a cable that will connect with the handpiece. Yeah. We are going to see this afternoon. So 3504, I transferred the working length for the mesials. So what I'm doing is I put my file. If I feel some resistance, withdraw 1, 2, 3, 4, 5, 6, 7, and those are 5 seconds. Again, same thing. If I still feel some resistance, I withdraw. Brushing, 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 brushing. 5 seconds. Now I put 18 millimeters here because it's the distal that I'm going to work. So let's go 18. This ruler is not the best one, but, and I'm going to the working length with my 35 because the distal allows me to do that. So I'm just doing circumferential instrumentation. Here we go. What happens now, you know. Irrigation. So again, I'm coming here. The good thing is you don't need to fill syringes. You don't need to refill syringes. You don't need to have 10 syringes in your operatory table. Everything is coming from the reservoir, so, right? Thank you. I know. My mom always say that. Yeah, thank you. You don't need to say in front of everybody. You can have some privacy. Oh, you're talking about the technique. I understand. You are so cool, my love. I understand that. I'm just kidding. We Brazilians. Oh my gosh, if we do this here in the United States, you go to jail. Brazil is such an interesting place. So, for example, I was the head of my department, so I have 2 assistants, right, in the lobby of the department, and I have every single day. If you don't go say good morning and 2 kisses in each one, something happens. Give 2 kisses in your assistant here, and you're going to the judge and sexual harassment or whatever. Even touching. So you guys see, David, for example, I always, hey, David, pow. David, pow. And David this, and David that. Or you guys, I always. So one day, my wife came and said, you have to stop with this. Because people will think that you're trying to, do something. I said, I'm just saying hi. No, don't use your hands anymore. Don't be Italian. And in Italy, we kiss male. So you come and you say, ciao. Ciao is oi. Ciao is hi and ciao is ciao. Ciao is hi and ciao is bye in Italy, right? So you go ciao is hi and you go ciao, this is bye. It's kind of weird, but... And you kiss if it is your friend, right? If it is not your friend, you just take a bullet in his hand. Very Italian, right? Very mafioso. So again, I'm doing a lot of irrigation, 30 seconds in each canal. Bam, it's up it. And patency. Or patency. In England is patency, in US is patency. Here, here, and here. Super difficult. Tedious. So now I'm finalizing with my 35 on the medials, and I'm putting the number 40 on the distal, right? So on the medials, you were hidden there. But I'm talking about you. Did you see that? Okay. So here, just to make sure that I'm at the working length, and I am actually, beautiful, right? And let's put 18.5. This is, I guess that is 18. Yes, it was. Okay, so now I have my space there to the working length. Mesiolingual, mesiobuccal, the same. So it's beautiful there, right? As you can see. And in the distal, because I already opened space with the 35, now I'm going to with the 40. Because distal is a little bit larger, so enlarge a little bit more. I can go with the 50 if I want, because the 50 is a gold heat treatment, it's super flexible. The 40 is gold as well. And that is for purpose. You remember the explanation yesterday, right? So each heat treatment for each file. So, as a federal university professor and faculty member till today, even though I retired, but I still head of my department there. Not for an executive point of view, but in Brazil, when you are head of your department, you are always be head of department until you die. Then the other one that is head start to be. It's kind of a different situation. But anyways, all my patents, everything that I did, all the royalties goes to the Brazilian government. That's why we don't have a lot of people doing anything there in terms of intellectual property, because it doesn't matter what, it's going to the Brazilian government that is not corrupt, that will, use this money wisely, right? One day I was seeing the CNN or Fox News, I can't remember what it was, and somebody said, this government is corrupt. I always pick up the phone and say, hey, you don't know, you don't have a clue what is the real corruption in a government. Because if you have a clue, you'll see that these millions that you're talking about are trillions in Brazil. I will give you one example. I hate to talk about politics, but this is so crazy. The last Brazilian government, that was a socialist government, sent $1.8 trillion to Cuba to make the port. That is a big port that Cuba has now, that everything that comes to US from South America needs to stop in Cuba, pay some fee, and go. This $1.8 trillion just gave away, like, it's not even a loan, it was just money for Cuba. Because we don't need hospitals, we don't need schools, we don't need anything in Brazil. There's plenty of everything there. There's no social contracts, there's nothing. Everybody's happy. It's so happy that we are giving money to Cuba. Puta que That's why I'm here. American citizen now. I love Brazil. I love my place. I love the food. I love the trees. I love the weather. I miss my family a lot. But that's it. Nothing more. Even the carnival I don't miss. Anyways, 40. I'm going with the 40. You see, my 40 is going there. Easy, beautiful. And this is what we are going to do today with my 40. Always circumferential, and that's it. If you need more instrumentation, you have to stop. You have to do your irrigation, patency, and go back, right? Don't stay more than 5 seconds. I think that I told you this like 15 times now. But it is important. Now is my, let's say, pre-final irrigation. Why pre-final? Because I want to make sure that my tip is going to the working length. You see the red point there? Oh, you cannot see, right? But there's a little red point. My tip is going to the working length. Is the only way of going with irrigation passively to the working length is with this technique. In the near future will be another technique that will be exactly the same, but will be a cannula. And this cannula will suck at the very same time. So you are going to have vibration, irrigation, and suction at the very same time. Cool, huh? Do you want to see? I will show you. Not now. Are you recording this? Oh, you are going to cut this part. You are. You are so screwed if you don't do that. Honestly, David, this is serious. Why you don't go home, David? You don't have to do anything. Ay. Okay. David is my buddy. I like this guy. And he's an awesome professional. If you need anything video, just talk with him. He's good. You are going to cut, right? I told them that you are good and you're a good buddy. So this is my pre-final. And I told you it's pre-final because I need to do some things before going to my final irrigation. One is patency, just to make sure that my foramen is secure. 1, 2, 3, just like that. Okay, 1, 2, 3. It's kind of poking, dum, 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 right? And now I'm going to use my gutta percha just to see if my gutta percha is fitting. You see that my canal is filled with sodium hypochloride, and this is good, right? This is the conform fit that I, no, this is a big shadow. This is the conform fit that I told you yesterday. Conform fit. Conform fit. Vortex and Vortex Blue, you are going to buy, you can buy assorted, right? Then you are going to have 10 of each. Conform fit from this company here. You see the company? You see the company there? Conform.
0.04 or 0.06?
0.04, because we are using just 04. Forget about 06, okay? You see the company there, Greg? The company there? You see the company there? You don't see the company. You are going to cut this. You are going to. No. Okay, I will provide you coffee every single day, espresso, kiss in your cheek. No? No, I don't think so. Okay, so I will take a 3504, right? It's just 04, okay? Clear, just 04. 06 will not fit on a 04 preparation. So I put there, look at that, right? So remember, we are 1 millimeter off the foramen. That is for purpose, right? This 1 millimeter will be filled with sealer. And again, here, same thing, 1 millimeter, right? And of course, the last one will be the 40, right? So let's put another 35 there. And let's put the 40.
Do you ever, like, have to go up on the gutta percha because it doesn't tug and all that? Or are you always, if you do the sequence like that, are you always right there?
I wish to say I always do things right. And I wish to say I always have 100% of success. But you know that that's not the real thing. But to answer your question, I'm taking some precautions here. First, if you do your instrumentation 18.5 with a 3504 Genius file, or 3504 whatever file it is, and you take a conform fit gutta percha cone, not that gutta percha cone hand roll it. Have you seen how they do, how they make the gutta percha? It is hand roll it. It is roll it by hand. Like you take a piece of, it is weird, but it's true. You take a piece of glass and you heat this piece of glass at a certain temperature. And another piece of glass here with a certain temperature. You put a little ball of gutta percha, and this lady, and it's always ladies, I don't know why, but this lady come and start to do rolling like this, and give this taper format like a cone, and with some magic, they know what is 20, what is 25, what is 30, what is 35. Are you kidding me? That this gutta percha will fit anything? So, because conform fit, I tried to buy more conform fit, but I don't know, I thought that I had more. So what I did for you guys to use, I took a regular gutta percha, right? And I take a box of 3504 and I use a ruler that is called Calibration Ruler. This is a calibration ruler, right? So I have my ruler here, and I have these little spaces here, as you can see with numbers. You see those holes here? You see there? See? 70, 80, 60, 25, 35. You see? This is a calibration ruler, right? So what I do is, to be fair with you guys on the back, I will make them to see, because I'm evil. So what you have to do is this. You have to take a 25 or a 30, because they are so bad, and you put here in the 35. I'm doing this for purpose, just screw up your video. Ah, no. Ay. So I put here in the 35, and if it is passing a little bit here, I come with this little lamina in. So this is the calibration ruler. So I'm making a 35 from a 25. Believe me, 80% of the 25 doesn't fit on the 35. They are more 40 than anything else. So to make some cones for you guys, I had to stay an hour. Each one. So go and buy the conform feet and wait, because next year we are going to have a good pressure that it will be molded, not hand rolled.
Is that why whenever you're obturating, it comes back out?
Yeah, because even is not going because it's too large. Even is not. Even is when you press, deform the tip because it's too thin. So it's not calibrated. Mainly hand rolled gutta percha will give you always, and always the professor comes and says, you need to have the tug back resistant, or why you were using this, you are far from the. I said, well, I did exactly what you told me, teacher. And, oh no, you're doing wrong. No, you're not doing wrong. It's because hand rolled gutta percha don't fit at all. Period. From a box of 100, that's why you pay $8, $10 in a box of 60, right? And then when you're going to use, a 25 is a 40 is a 20, right? So use the conform feet for now. For now, because we are coming with something as good as half of the price. Okay? Nobody asked me where I bought this ruler, right? Because I bought this ruler in Europe. Actually, I have just two, right? There are some calibration ruler here in US, but you have to use a scalpel, right? This comes with this super cool little scalpel here, slide, but maybe not you can find. This is from Woodpecker. The Woodpecker R1 Plus is called. Made in China. Very precise. Okay? Those are calibrated yet. So I will put back here because this is the way that you guys are going to use. Let's see if it is fitting there. I'll tell you the truth. I used to have 100 of this. All the last and before the first group I gave as a present, as a gift for each one. Last group I give as a gift for each one, and the box disappeared. Yeah, the box just disappeared. It's not here. It's not in my lab. It's not in my office. So I don't know what happens. Usually I give this as a gift. So, but yeah. Okay. So I will put this as a 35. This is a conform fit, right? And this is the one that I did. So you see, it's not going there. So the conform fit is better, even better than these ones that I giving to you to use. So the best one is the conform fits. It's not a problem of your preparation, it's a problem of how to manufacture these guys. It's so well manufactured that you can see here that at the tip, you cannot see, but there's a number here, 35, right? So I truly recommend these tips for you. Okay, once I choose my gutta percha points, I will just remove these gutta percha points here and I put, of course, in a gauze because they are clean. Now, and they have to dry because I use sodium hypochloride. Now I'm doing my final irrigation, okay? Carlos, 80% of your stuff is irrigation. Yes. Yeah. And that is true.
Would you have dried the canals to fit the cones?
No, for purpose I put sodium hypochlorite because the cones will be disinfected,
Okay.
right? Okay, so now I'm going to use EDTA and then for 1 minute, sodium hypochlorite for 1 minute, and still water for 1 minute. Is that okay? So I was using sodium hypochlorite. Now I change my bottle for the bottle of EDTA. Put a bottle of EDTA.
So just to be clear, it's 3 minutes per canal by 3 canals, so you're gonna, this stage is gonna be 10 minutes.
111, yeah, 9 minutes for a molar. It's too much. But, okay, so you're touching a very sensitive point, right? The reason that I came with this protocol is because this is the official protocol, right? As a PhD, I know that my peers, PhDs and other people, will study this, and they are. And you saw the study. Yesterday I showed you a very clean canal, right, to the apical part as well. This is for a very infected situation. This is when you have biofilms, you have a big lesion, and you want to make sure that everything will be clean perfectly. Plus, I need to do that because people will test under my protocol. Doesn't mean that you have to use 1 minute, 1 minute, 1 minute. I would say that the most important one will be the last 1 minute with distilled water. That will be the most important one. If you want to do 30 seconds EDTA, 30 seconds sodium hypochlorite, and 1 minute with water, that's okay, that's fine, per canal. But in situations that you have low infection, a necrotic tissue but without a big lesion, is not an abscess, situations that under your judgment you think, well, this is not super infected. I can shave a little bit the time of EDTA and sodium hypochlorite at the very end. The way that I'm showing you guys is for the top infections, right? From a situation that is the worst. Under your judgment, you can shave a little bit of the time on the final irrigation, yes. But always 1 minute with distilled water because you are making sure that you are removing all the liquid from your system plus from inside the canal. Does that make sense? That was a good question, even though, you know, it's a hard answer because I cannot say, well, in this case you use this, in that case you use that. It's so many different situations, right?
What would be a situation where you don't finish at one appointment? Is there a situation?
Oh, absolutely, yes. When you cannot dry the canal, when there's some exudate or some pus, or if the patient has a lot of sensitivity, a lot of pain, it's a very big lesion with a resorption, apical resorption, and I want to make sure that this old big infection will be deal with an extra protection that is calcium hydroxide? Yes. But honestly, the majority of the cases that is not on these situations, I can do in a single visit, yeah. Just because time.
For most GPs, I mean, we tend to start a root canal and finish at the next appointment. Well, I do.
Mhm.
Once I prep for a crown, gotta wait for it
Yep.
to come back.
Yep.
So I guess, you know, if you're gonna use like some calcium hydroxide or whatever, you can probably start it, get most of the pulpal tissue out, get to the working length, and then put some calcium hydroxide in it.
No,
Don't do that.
don't do that. The ideal is finish your instrumentation and then put calcium hydroxide. The reason that I don't want you to do that is, one, you don't have space for the calcium hydroxide, and calcium hydroxide needs to work in contact, needs to have contact. So if you put calcium hydroxide in the cervical third, is not working the apical third, somehow it's okay because you're just getting some time, right? But just remember, calcium hydroxide needs to be effective, needs to be 10 days to 2 weeks, 10 to 14 days. Doesn't mean that you have all the time to do that, because it's a matter of purpose. Let's say that, like you said, I want to start, but I want to finish in the second session because I will do an obturation, I will build up and do a prep and put a temporary crown. That's a good strategy, I agree. Even though I don't like to mix endo materials and procedure, they don't like. The assistants hate that. When you start and finish an endo, you start a prep and do a temporary crown, they hate it. Because it's too much material, it's too much preparation, right? And all the things will be different. So you don't like to mix endo stuff with restorative stuff. But let's say that you want to do that, and you want to build up and prep and put a temporary crown. So all the obturation phase will be in this second visit, not the instrumentation. Okay?
So you would put the formal cresol pellet.
It depends. It depends. Pharmacresol pellet, if you want to do in 3 days, 4 days, the next visit. Calcium hydroxide, if you want to have in 10 days.
But not into the canal.
What?
But not into the canal.
What?
I mean,
What not in?
well, I was kind of thinking about this too. So I'm in the same boat as him. Like, usually what happens with me is I'll be doing a resin or doing something, and we'll have a pulp exposure.
Uh-huh.
And if I was gonna do the endo, I would bring him back.
Yeah.
So I guess my question is, sequence-wise, would it be better just to make sure I can access the canals, and then what's the best thing to put in? Like, I'm not removing any.
So if you're not putting any file inside the canal, pharmacresol.
Okay.
If you finish your instrumentation and you are going to stay for at least 10 days between one session and the other, calcium hydroxide. But if the patient has any sensitivity, pharmacresol. Even if you finish your instrumentation, if the patient came with a lot of sensitivity, came with pain, then don't put calcium hydroxide. Calcium hydroxide is not good for pain, actually it's the
I
opposite.
guess my question is, if I know I'm not gonna do the endo that day,
Mm-hmm.
is it safe to say, make sure I can access the canals with like a small file?
Nope.
Formal cresol?
No small file, no file.
Nothing.
Open, identify the canal openings, control the bleeding. You can use ferric sulfate if you want. Control the bleeding, see, but do not touch the tissue. Do not poke that tissue, because you are just increasing the trauma, right? Pharmacresol, temporary restoration.
And you can't irrigate into the
You
pulp?
can irrigate the pulp
Just
chamber,
not
yes.
into the canals?
Canals, no.
Okay.
Avoid the trauma. Yeah.
Carlos, how often do you prescribe antibiotics?
Antibiotics is a discussion, a full discussion. Of course, in those cases that you have a infection, acute infection with pus, exudate, and the patient has some problems like me, thrombophilic, or any kind of a heart disease, diabetics, those cases that we know, right? So the patient comes with a systemic disease. Those are cases that I like to use antibiotics. For regular cases, almost never. Almost never. I had some cases that the patient had come with fever and systemic, he was like this and it just fell and opened the mouth. It was with fever and he was kind of a weak. So when I drained the abscess after, and antibiotics always after you did your job. You are a surgeon. You have to drain, right? Hippocrates said that. Drain and medication, not medication and drain. With exception of patients with systemic diseases like AIDS or thrombophilia or heart diseases, there's a list. Just go to the American Cardiology Association. There's a list of preventive antibiotics. You know what I mean. Yeah. Okay? But drain. This is what we have to do. So let's say that you open and nothing comes, and you know there's an abscess there. You have to come with another procedure that is a surgery draining. So you have to, open everything, make a hole on the cortical bone, try to find where is the abscess, and try to drain from the bone. This is not very nice, not very simple, needs some training, but yes. If you give antibiotics for a patient that you cannot drain, what happens is all the pus will be solid, and then it will be a nightmare to treat, right? My intention is to have all the groups together back in LVI next year and just talk about this kind of stuff.
What's your protocol for if we're placing a fiber post, like as far as irrigation goes, after we get the post space created? You just run distilled water through there? Or?
Yeah, distilled water, yeah. But for the fiber post, it's like here, right? Avoid to produce debris. Because to remove debris is avoid to break a file, because to remove the file. So when you are doing your preparation for your fiber post, avoid to use burrs. Try to cut the gutta percha with a heated instrument. Try to remove this gutta percha. Take a look and see. If it is necessary to just adjust a little bit, use a burr. If it is not necessary, because today we have fiber posts, and fiber posts is just to help build up. It's not to give more resistance. Actually, it's the opposite. Every time that you cut denting, you are decreasing resistance, right? So yeah, and you can use the polysonic tip as well. Okay, so now I finished my irrigation protocol, EDTA, sodium hypochloride, distilled water with my polysonic tip. Now it's time to suck the excess of the liquid that is inside the canal, and I will do that. Just give me because I'm thank you. So I will take this big syringe. Of course, this is not what we are going to have in our clinic, but I'm going to do that because we don't have the aspiration here. So I will do this. It's kind of a manual thing, just to make sure that everything is clean. And now it's semi-dry, right? Thanks, my friend. And I use...
Clinically, what using suction?
No, I'm using suction and paper points right now, actually. I'm putting 3504 paper points here. 1, 2, and I use number 40 to the distal canal, right? And sometimes you have to use another one. Make sure that you dry, beautiful. Dry and dry. Here you go. So now I have dry canals, everything is dry, everything is beautiful here. Okay? Now it's time to do our obturation. So I told you yesterday that I saw something moving inside the canal. Maybe it's just a little water. Yeah, right? Oh, yeah, because there's some residual water in this little part here. Just make sure that everything is right. Okay. So yesterday you noticed, well, because time and kind of I didn't talk too much about obturation yesterday. Here you go. So I didn't talk too much about obturation yesterday because of the time, mainly, right? Of course, I have tons of slides about obturation, but I will show you this obturation that is super, super duper simple. Bioceramic sealers. Why we use bioceramic sealers? One, there's attachment with dentin. It's the only sealer that has a chemical reaction with dentin. So you are going to have, by time, you are going to have a chemical bond interface between the bioceramic sealer and dentin. This is super cool, right? Another thing is bioceramics, MTA-based materials, they are osteoinductors. It means that whatever is touching this material, the cells will start to make bone, if it is bone, or dentin, if it is dentin, or cemental, if it is cemental. So when you have this in place, just remember that not only will be not aggressive, but will happens induction, a biological induction of some sort of hard tissue, right? And they expand. Instead of contract, they expand. 0.1% is just a little, but it's better than shrink, right? So those are the good things. They come in these cigar things here, right? And the reason is because they are very sensitive to humidity. So remember, this is a pre-mixed material. How this material set in contact with water from the dentinal tubules, right? So that's why you have to, when you finalize, you have to tightly put the cap back, right? Open this, put this here, and close, especially in Florida. That is very humid, right? Dr. Primus is from Florida, actually. Okay? The inventor of the thing. Okay? So you remove this, and these kits here that they send to us. It's a very nice company, actually. I open this. So in this kit comes the IFU, of course, and comes with this, and with some tips. So it's called FlexiFlow tip, and this tip is made by PIC, like the polymer tip. This is a cannula made by PIC, polyether ether ketone. I would say you need to have, I think that you have to open with scissors. I think so, yeah. We don't have it, right? Look at that. I will leave here just in case, right? If you guys need it, and you will. So you open the little bag here. Why this bag is like this, I don't know. This is not gold or something, right? So you take one of this. Well done, Carlos. 30 minutes to open one bag. And you uncap, put the tip like this. Make sure that it's tightly put. Here, there's a rubber stop, right? So the secret is this. You are going to put working length -5. So instead of 18, I will work with 13, 12, 13. Okay? Let's do that. And why? Because I don't want to go to the working length with this and squeeze material, because after this comes a gutta percha cone. Right? So what I will do is I will put 15 here. Make sure that you put 15. It is. And I will squeeze just a little bit, just to make sure that it's passing through the cannula. Here we go. This is actually too much. Sorry. And now I will put inside the canal like this. Right? And I will start gently to squeeze inside the canal. Let me do this. I think now you are seeing there. Better, right? So I will squeeze like this and retrieving the tip. Just like that. I don't need, once I see, I'm seeing like this. When I see coming, I just stop, right? I don't want to overflow this to the pulp chamber because it's a waste of material. I will remove after that, right? And I'm going to do the same thing on the mesial buccal. And the mesial lingual. Okay, that's it. Now I put my gutta percha cone. How I put my gutta percha cone? You remember yesterday? Slow, like super slow, but it needs to be one movement. So if I stop, I have to stop. Don't withdraw and go back. Don't pump. So I put my gutta percha cone there, right? You see that? And slowly, but it needs to be super slow, right? You see there's something going there? Until I reach my working length. Just like that. Okay? And I do the same with my 3504 in the other canals. Super slow. Just put there and go very, very, very slow. Here we go. And another one. Same thing, very slow. Ta-da! Sealer, gutta percha sealer, gutta percha sealer, gutta percha sealer. Okay? This is the goal. Little training, but nothing impossible to do and nothing rocket science. It's just like that. Let's cut this gutta percha. So I will remove my tip from here, right? I will take my wrench. I will remove my tip. Okay? And I will put my EG17, that is the gutta percha cutter. Same thing, clockwise. And I use my wrench here. Because this is has more metal mass, I will use the power number 8. Okay? And I'm using the reservoir. I don't need water with this dude. I don't want water. I want to heat it, right? So I will press the faucet button there if my equipment is not hooked to the water. If it is, what I will do, I keep the reservoir, but I just turn the knob down to close the water from the reservoir. Is that okay? Either or. So what happens now, I will turn on, and you can see when I turn on, I have vibration, and with this vibration, will heat my tip, right? So I will show you how it works. See that? Did you see that? And I will do the other one, and I will do the other. So I remove the big excess first, the big excess, first, the big part first. Sometimes to translate from Portuguese in my mind to English in my mouth, it's complicated. And now, what I'm doing is I will cut to the opening, to the access, to the canal opening there. So I do the same thing, but now I'm going a little bit deeper, as you can see there, the tip. Let's do the distal. Here. Oh, by the way, in the distal, if you want to hook another gutta percha, because you have some space, you can. Let's try it. You can RPM another gutta percha here, right? Because in the distal you have more space. I like to do that. So you cut here, and now, of course, I will cut at the canal entrance, right? So I will do the same thing. Here, you see? Sometimes the gutta percha comes with. So, if that's the case, you have to put another gutta percha and train a little bit better. Same thing here. You know, I like to force a little bit the tip against the canal entrance. Make sure that I'm cutting everything. And do some kind of condensation. Same thing here. Do some type of back and forth, and then you have the fragments here and the fragments here. A lot of people are cheering to the gutta percha come with right now just because it's a demonstration, right? I don't have my condensers here, but if you want to do some vertical condensation, you can, right? If you're not comfortable with this process here, you can always go back to your regular cutting with hot instrument, right? There are some instruments that you can buy actually that is heaters for condensation, so you can use those as well. This is just another way of using ultrasonics. After that, as you can see, I still have some pieces of, let me try to do this. I have some pieces of gutta percha there, right? And some pieces of cement or sealer. What I will do now, I will turn on the water, go back to the water, with the same tip, what I will do, I will clean everything. So I will come here and I start to clean everything. With the very same tip, I'm sorry. With the very same tip. Let's put like this. Better, huh? Better? Yeah. So now I'm cleaning all the pulp chamber, removing all these little parts of gutta percha, eventually, or sealer. With my ED70. Ta-da! You see that? Beautiful.
Any light? Travis, do you have a light you could draw on this? It's hard to see.
Yeah, they have the monitor. I think that they can see. I think this is the maximum light that I can do, Sean. Yeah, the monitor you can see better. Oh, not here. Here is yeah. Anyways, can you see that? The 3 canal entrances with the gutta percha. That's it. Now flowable composite. Boom.
You were loading the bioceramic in the 3 canals before you placed the gutta percha in the 3 canals.
Yeah.
The working time or the setting time on that, is there plenty of time to
2
do 3
hours.
canals like
Yeah.
that? You're not going to get in trouble
No.
because you're taking too much time?
No. It is 2 hours minimum. Yeah. It take actually one of the downsides of the bioceramic sealer is the setting time. The setting time is kind of 2 hours to 10 hours, 12 hours. So it depends on the humidity inside the canal that you leave.
And you said no water on the Sonos when you're cutting the trends off?
Yeah.
Okay.
Yeah, because you want to heat, right? So no water.
So, if the setting time's that long, is there a reason not to do a post space right away if you were gonna do a post space?
The only problem of putting the post or doing the post or whatever you want to do is the fact that the sealer will be not set, meaning that this gutta percha can move, right? So you have to be careful with that. I would say that the best sealer to do a procedure like this, like immediate post preparation, is the resin-based sealers, like H+, like Endores, like all the sealers that is resin-based, and because they are fast. But even those, the setting time is always 15 minutes, 20 minutes, right? So just if you want to wait, set up the sealer to prepare your post, you have to wait. Doesn't matter too much if it is a resin-based sealer or a ZOE sealer. You have to wait at least 10 minutes, 12 minutes. In the very past, we had these fast setup sealers, ZOE sealers that you use. But ZOE nowadays is not very common to see. At least you cannot do this kind of technique because ZOE shrinks a lot, right? Resin-based sealers shrink as well, not as ZOE, but shrinks. These bioceramic sealers, they expand. So that is the big advantage actually of these sealers. What you are seeing here now is the little surplus of the sealer on the very apical area here, right? So you can see the surplus there. And honestly speaking, this is an open situation because it's a block. Inside the mouth, of course, you have tissue there that will be somehow will stay or keep your sealer inside the canal with a little surplus, right? This is an open space, so that's why there's a better flow of the sealer outside. But you want to you don't want to sealer outside, but you want that area clean, that last 1 millimeter clean. So that's why the sealer will flow there. And believe me, it's a matter of the resorption of the foramen, or the state of the diameter of the foramen, that you are going to have more or less extrusion, right? And extrusion itself, the sealer itself, is not a problem. Problem is what goes with the sealer. So back to our preventive situation, clean the canal perfectly, don't extrude debris, don't extrude any kind of endotoxins. That is the problem. The sealer itself being extruded is not a problem at all, especially bioceramic sealers.
How comfortable are you with, say you have a short obturation, but you're pretty darn confident you got it cleaned all the way to the end? I mean,
I saw some obturations that was like 10 millimeters in the central incisor, and in this central incisor never had any problems, right? This is a very difficult assessment, because if you take an X-ray and you see that it was not you, right? But from now on you are responsible for that case. At least you are responsible to say, hey, you have a situation here that needs a follow-up. And if you have any pain or anything, any sensitivity in this, you have to come here immediately. Because you have a root canal here that has that lead to a good result for now, but we don't know what will be in the future. I hate to say you have a root canal here that was not very well done, because the judgment that you are putting on the other work will be the same that people will put in your work, right? And we have to break this chain. We have to stop to do that. Nowadays we have so many resources to follow up, but we don't have the knowledge to know what happened at that time. So I had one case, my case, that was a kid that was a lateral incisor. And I made a process called Epicogenesis. It means that I use MTA since Dr. Tarnaminejai started in Loma Linda. He sent to the university. So I put MTA in the Pope chamber, right? But at that time it was very hard to control. Until today it's very hard to control MTA from them. This MTA here, I have a putty MTA here that I will show you, that is very easy. You just create a little ball and you do some condensation. It's kind of a soft gutta percha. But at that time, I squeezed too much MTA inside the canal. It was kind of a central incisor was like 2/3 formatted, and I put MTA in this. I just left 2 or 3 millimeters off, right? And that's okay. So the same patient went to another doctor 5 years later, 6 years later. And the doctor called me and said, hey, you did a very bad job here. This obturation is short. I said, well, maybe. Can you send me the X-ray? Can you elaborate a little bit more? Yes, the patient said that 5 years ago, 6 years ago, he went to your office, and he started to describe the patient, and all of a sudden he described the patient's mother. And we know what is a kid's mother when in a trauma, right? Desperate. And I said, well, I remember her. And by the way, when I did this treatment, I did with MTA. And this is an epicogenesis, meaning that from the MTA, the roots start to grow and close. So obviously, it seems like a short obturation, but you know that, right? Oh, I didn't know that. And what you said to the patient? Oh, no, I didn't, no comments at all. Oh. Of course he did. So we have to understand that and let's say that, forget about this explanation. Let's say that you try the best that you can right? And in that moment, you are not able to find the canal, or you are not able to negotiate the canal until the end. Who are me to judge this situation that you are passing through? Maybe you are having a problem. Maybe it was not the best day. Why I need to judge, right? So even fracture files, separate fragments. If the patient comes and says, I will do my best, but your anatomy here is very complicated. There's a piece of fracture file there. I will not tell. I said, it's so complicated that somebody tried it and was not very well succeed. I don't know if I be succeed or not until I try it, right? And if I try and I'll be very well succeed, then I will charge. If I try it and not very well succeed, you have to remove, put an implant, and done. So we have to break this chain of talking bad about other people's job, right? Because one day it can come back to you. But yes, if it is short but it's clean, theoretically, remember that I told you, it's never clean, it's never sterile. Well, I would say that the odds are that you cannot sterilize the canal. Even with these 30 minutes of irrigation with sodium hypochloride, EDTA, etc., that I hope that you start to do it. I really hope. Because after 30 years of endo, I did a lot of stuff. I did good and bad stuff. But I never had any problems when I exaggerated, between quotes, in my cleaning process. In my cleaning process, no. Other than that, I try to cut some corners. I try to do in 30 seconds, not in 1 minute. And I'm confident that those are the ways that you failure, right? Because, man, this is a bugs situation. This is an infection situation. We are dealing with infection. If you don't clean, doesn't matter your obturation. And we dentists, we are very, we have this tendency of putting materials in front of the biology. We do that because look at this, look at that, right? It's all about materials and materials and materials. We have special orientation on dental materials, right? Alginate and ZOE and this and that and resins and artificial teeth and all the things. But in endo, you are dealing with an infection period. That's why when you do vital pulp, a pulpectomy on an irreversible pulpitis, you can do a short obturation. You can be 3 millimeters off. You can be 2. You can, I did my irrigation, but was just with water. Doesn't matter too much because there's no infection component, right? At least not at that moment. That's another thing. At least not at that moment. Because you have infection, you have the presence of bacteria in your blood, in the patient's blood. And there's a communication between the bloodstream and a canal that is empty or is not very well done. Anyways, the bottom line is, in a vital situation, in a non-infected perspective, I can cut some corners, I can shave some time, yes, but not in an infection, right? One of the problems of dentistry, and especially endodontics, is the fact that diagnosis, we are in the ice age of diagnostics. Really. CBTC came to put some lights on diagnosis, yes. But mainly, we are in the ice age. We know when it is a necrotic case or not a necrotic case after we open the tooth. Before that, You can guess, you can put an ice, nothing happens. How many times I put an ice spray, the patient said, no, I don't feel anything. I open blood. I remember my dad was a canine. And I opened without anesthesia, and all of a sudden he say, I said, I what? He say, it is hurting. I feel some pain. I said, Dad, you are a robot. You don't feel pain. He said, but now I'm feeling pain. I said, oh my gosh. And it was a canine that I diagnosed as a necrosis with no lesion. I opened without anesthesia. My dad, the guy who paid my bills forever until today, and guess what? Start to bleed. And then what I did, one of the most excruciating pain that you can have in a millisecond is an intrapulpar anesthesia. Have you had one? I had. It's kind of a super duper sting bee inside your brain. I will try with my friend David right now, and he was he was paying so much attention, poor guy. He was like this. Jeez. Hey, what you're hearing is not outside. Don't tell your brother and your sister and your mom that dentists are stupid, right? We are not. We are trying to do our best. Anyways. So where I was about anesthesia, right? So yeah, go ahead.
So you won't do direct pole count if you have a pinpoint exposure, you just root canal?
No. We always try to, and now, and this is a very good question, because now the American Association of Endodontics finally recognize a vital pulp therapy with MTA on these situations, right? Because until 6 months ago, they didn't recognize pulp capping as a vital pulp therapy. Yeah, that is the American Association of Endodontics. But when the insurance company start to pay for this kind of procedure, then the American Association of Endodontics, you are recording this, right? You are going to erase this. No. I have to pay you to do that? Jesus, man, I'm so screwed. I love the American Association of Endodontics, and they are very nice, and oh my God, they are super. I love them. Mwah. I love that supply. Wavy one is good. I am stupid. I'm the dumbest endodontist in the whole world. Okay, now let's go back. Okay, so the insurance company now are paying for this procedure. So the American Association of Endodontics say, no, this is good to go. Because now they are paying, right? But yes, you can.
And you do it with
But okay, no. You are going to the wrong direction. Again, this conversation is about materials, and I told you, we have to go to the biological part first and then use the materials, right? You want the fast answer. You want the easy answers. And we are human beings. We love that. What you are going to put, MTA or calcium hydroxide or putty or this? No. First of all, you need to know what is the stage of inflammation of that tissue. Because no matter what you put there, with or without the Holy Father blessings, it will not work. It depends on the stage of inflammation of the pulp tissue. So it needs to be a reversible pulpitis. How you recognize a reversible pulpitis versus an irreversible pulpitis? Well, pain is extremely subjective, right? Extremely. But again, we are in the ice age on the diagnostics in dentistry. We don't know what is the type of bugs in the infection. We don't know even what is a reversible or irreversible pulpitis or a transitional phase in between the two. We cannot recognize that. The only thing that we can is to guess. So, that being said, there are some things that you can do, right? One of the things that you have to do always, and you are not going to do that, I'm sorry to say, nobody will do, but you have to, is this. Buy a spray, those sprays that drops the temperature, you know, those Endo-Eyes. Buy one, and every time ask your assistant to put this spray in front of you with, what's the name of that thing that you, huh? Q-tip, with a Q-tip. I will kill you slowly. Slowly, if you put this.
If somebody did to his dad,
Yeah, no, I don't know what you're doing there. I don't know why you're taping all the thing. You said that you want seconds. Seconds. It's hours that you're doing this.
You're like, look, dentists don't even know what
You are going to sell on the internet, anyways, what I was, Q-tips. So you have Q-tips and a spray every time. Patient come, you are going to do your diagnosis, right? So you see the restorations that you have to change, So, okay, you ask, have you feel anything with this in your mouth, like any point, anything that hurts? No. Okay. So before start the restorative preparation, the preparation, removing the caries lesion or removing the old restoration, before anesthesia, of course, try to do a diagnosis of the pulp stage, right? Q-tip, psst, wait 10 seconds. It's not psst and go. Psst, wait 10 seconds. See the little snow there. And then you go to a normal sound tooth, close to that tooth, or a lateral central incisor. You go to the right and then you go to the left, right? Try to get the information of a normal response, of a sound response from that patient, because it's customized. Do you really think that me, as a coward, I will have the same information than David, that is a hero? No, David is a tough dude. I am chicken, right? So each of us, we have a pattern of response to ice, right? To drop the temperature. It's a C fiber termination that will give you this response. C fibers are the same that you have in your belly, are the internal organs fibers. You know that for study, the neurologists, to study pain, the best model is a tooth, because the tooth has the 3 types of fiber. It's the only organ that has 3 types of fibers, A, B, and C. Right? But this is a long conversation. Let's go back. So you go there and you determine what is the normal response. After 10 seconds, Greg here say I. So this is the normal pattern, the normal response for a sound tooth. So I take the same thing, wait 10 seconds, see the little snow, and then I go to the tooth that I will go to restore. And I put in kind of in the same situation. If I'm going cervical, I go cervical. If I'm going in the middle of the crown, I'm going to the middle of the crown. Try to repeat. And Greg will say after 3 seconds, I, and this I is worse than the first I. Well, there is inflammation there. And look how primitive we are to do diagnostics. I'm ashamed of saying that. I'm ashamed to say that I am a doctor that use ice and the patient I to diagnose. But this is the way.
What about the pulp testers?
Worse.
They're worse than that?
They are worse because electrical stimulus, you have to have more stimulus in electrical because it's mainly a little current that you're pucking there, right? The best still ice, dropping the temperature, not increasing, but dropping. Right? It's crazy, man, but it's true. So, oh no, but I can. You cannot. Period. Right? So this is one thing. If you have 10 and 3, wow, this is an inflamed situation. It's not the patient is not saying it hurts without anything, but it hurts when you do your test, right? So it's a reversible inflammation. Maybe just removing the carious lesion, maybe just putting a new restoration, this reversible inflammation will disappear and go back to a normal situation. Maybe we'll be there forever, and maybe we'll go to an irreversible situation. Look how complicated is your situation when you touch a burr in a restoration. You start to be responsible for the future of that thing. And who knows the future? He or she can go eat a popcorn and do a crack there, right? And that's it. It's not your fault. But it's a coincidence that you finish your restoration 1 week later, the patient starts to have a lot of pain. And you cannot see cracks unless you have a very good microscope. Not even in a CBTC you can see cracks. You see? So I love to make some, it's not jokes, I cannot tell you a joke, but I love to make some relations that we do and some fun just to relax us a little bit. But this is very serious. When you start something without knowing what is the pulp tissue status, without any try to do a superficial diagnostics, you are doing wrong. So let's say that you have this situation, 10 and 3, and you are going to the 3. You remove the restoration, all of a sudden, boom, you see some oil there, right? So a little blood coming. What is the type of this blood? It is something that bleed and stop. That is low grade of inflammation. That's good news. It is still bleeding after 1 minute, and you're compressing with cotton pellet, and the color pattern come red. And when you remove everything, it start to bleeding again and again. Oh no, I use ferric sulfate. Oh, you can use ferric sulfate. You stop the bleeding. You are not going to stop the problem. The problem is that is an irreversible pulpitis without symptoms. And that is very true, because symptoms are something that is very unique and particular. You see what I'm saying? So you have to understand that not only by symptoms, by seeing the bleeding, if it is start to bleed, pulpectomy, pulpotomy. Do a pulpotomy if you don't have time. Form a cresol, and okay, we are going to do a full pulpectomy and full root canal treatment because it is inflamed. I never feel any pain. Well, it's not because you never feel pain that you are not going to have pain. Most probably tomorrow you are going to have pain, and I am a superhero that anticipate that, and you owe me 10% more as a tip, right? Something like that. It's a full conversation, my dear. This is not, I'm just trying to answer your question honestly. And finally, if it's not bleeding, if you control the bleeding, after 1 minute compression and stop the bleeding, the tissue is a little bit pink, not super red, and you see all the things, MTA. You can use the putty. Where's my putty? I think that is here. Neocellular flow, no. Flow, no. Oh, it's here. You can use this one. The marketing team of Avalon Biomed is very bad because they put exactly the same color of the sealer and the putty, right? They should put, I don't know, red. But if you see the putty here, you can squeeze a little bit, Just a little bit, you see? And then use a little spatula number 1. Go there, put there, you see? I'll show you. Here you go. I can do a little ball. See? Look at that.
If you don't have these, what would be the alternative?
Huh?
If you don't have MTA putty, do you have any other?
Any MTA, actually.
Calcium hydroxide?
Calcium hydroxide will wash out very quickly. That is the old way.
Yeah.
No, use the MTA. Just buy. This is a lifesaver in your office for this kind of thing. Yeah, and it's not expensive.
And then you just pack composite on top of that? Or
Then you put the putty. Oh, what you can do is, I think that we were talking about this today. So what you can do is this. 2 options. You put the putty, and then you edge, adhesive, edge, wash, adhesive, and flowable composite to cover. Or sometimes I do this. Before putting the putty, I edge sideways and all the other walls and everything, not touching, of course, on the, because I don't want acid on my pulp tissue, right? So I put there, I wash with water, I put putty, and then I put the adhesive. So you see? So you can do both ways. Yeah. But putty will not wash out. That is the big advantage of putty. Will not wash out, right? I don't know you guys, but I'm super hungry right now.